Jason asks, how do we deduplicate the data? Do we aim for a certain percentage of accuracy? And if so, what is that?
Great question, Jason. In any quality measurement and reporting program, the first challenge is patient identification and its flip side, deduplication. It would be great to get a reliable medical record number from all of our clients about each of their patients. You'd be surprised at how difficult that task proves to be. It seems that even in rather simple, unified local health systems, there are multiple codes in existence that each uniquely identifies patients. Without a deep, intimate knowledge of the variety of information systems in use, it's hard to settle on and deliver a unifying identifier. In the simple environment of MIPS reporting, where submissions are on behalf of individual providers or single entity group practices, only about half of our clients are able to send a reliable identifier. In the much more complex ACO environment, it's nearly impossible, short of enormous investments of time, effort, and money, to implement and maintain an enterprise master patient index, which is the gold standard for getting a unifying identifier for all of the patients in a complex environment. Now, ultimately, you should be thinking about using the same process that measures your quality that gives you decision support. And when you're at that point that you'll use your quality data clinically, you should build a highly reliable system. I'd want something better than what you generate for a quality measurement if I were going to order medications, make other clinical orders on the system, on the data that's in these measurements. Now, it's possible to build a Six Sigma patient identification system, and we'd be delighted to help build that process and that reporting process based on it with you. But our healthcare system currently works at an overall roughly 2.7 Sigma error rate. That means there's about 111,000 errors for every 1 million clinical actions. And Medicare's QPP quality measurement system for either MIPS or the new APP tolerates about the same or slightly lower error level. And we have found that using first name, last name, and date of birth almost universally gives us the precision and patient identification and deduplication that Medicare requires. Now, if you need higher precision than that, either because the variation in your system is greater than average, or you want to be using your data more reliably in the clinical sense, we can customize your system to use other available identifiers. I'd recommend, short of the expense and effort to put in an Enterprise Master Patient Index, it's EMPI, insurance numbers are credible next step. That is, for each patient, you'd want to deliver insurance numbers for each insurance they've recently had, including Medicare. And we can use this to help us to identify a more reliable rate. Now, if you install and maintain an Enterprise Master Patient Index, we'd love to build that into your data flow to us, but you don't need that level of expense and maintenance to satisfy Medicare. We found that with simple manipulations that we can do of first name, last name, and date of birth, we get to a level of precision that defines your performance out to the second decimal place in percentile rankings, which is the limit of Medicare's precision in this process, which compares performance from practice to practice nationwide and compares your performance to yourself over subsequent years. And this approach will pass audit and has been passing audit, both those that Medicare requires us to perform on your submissions before they go in, and those that Medicare requires directly from you to check our work after the fact. So great question, Jason. I hope this answers it for you.